as it was broadcast, and you can watch it when it is convenient for you. Because we have a lot of a lot of new participants joining today, I'd like to start my introduction with the interpretation function for our webinar. In Zoom, today we offer interpretation into French, into Arabic, and into Russian. And to access the interpretation function, you go to the bottom of your Zoom screen, and this is the icon for interpretation. When you press that icon, you see the list of languages where the broadcast is available. And you choose the language that you need, and you hear the interpretation. Let us know if there is any problem with the interpretation, and we will do our best to address it. Now, because we have a lot of new participants joining today, I'd like to walk you very briefly through the webinars that we've had to date. We ran our first webinar in October 2019, and now it's October 2021. So we've been going for 2 years now. You can see the topics of our webinars in English, and if you need to see those topics and to review those topics, you can always send us an email and we'll send you the list. Now, all of our previous webinars, except for the 2 last ones, are available on our webpage. And also a few of the last ones are available on our YouTube page. So today's webinar number 18, the hidden complexity of implementing patient safety goals. Let me walk you briefly through our resources. First of all, we have IFC web page. We have you see how it looks on the screen, and there we have information. We have useful links. We have our blogs. So we welcome you to visit it. The link to that to the web page you will find in the email that we will send you tomorrow with the slides that were used during today's webinar, and also you have the link in your invitations. We also have a separate web page for webinars and trainings. And over there, you can find the recordings of our previous webinars, as well as the online training modules to improve the quality and patient safety at your medical facility. Those trainings are online, they're free of charge, and they're self-paced. That means that you can access them and you can go through them at your own pace. You can stop and then you can come back to them and continue when you have time. We also have Facebook. We also have a Facebook community of practice, and we highly recommend that you join us because it's a closed community. We do not have any unwanted information there, and we have a community where issues on healthcare quality and patient safety are discussed, expert opinions are provided, and useful information is exchanged. So the name of the community is IFC Healthcare Quality Community of Practice. We also have a YouTube channel that is called IFC IQ Health. And if you find it on YouTube now, you will see the broadcast of today's webinar, along with the recordings of previous webinars. Not all of them are there. We started our YouTube channel about half a year ago, so there are several webinars that you can access there. For participation in our webinar, there are 2 useful functions that are called questions and answers and chat. We always want to hear back from you, but there are good reasons why we cannot just open the floor to questions and answers. We have over 100 participants at the moment, so it will be very difficult to take over 100 questions. But if you go live, if you go voice, but you can ask your questions. Some of you have already sent your questions by email to us, and we thank you for that, and we'll prioritize those questions because they came first. For those of you who get questions during the webinar, we have the questions and answers function. When you press the button below that is on the screen, you see the field open, and when you have the question and answer field, you can type your question, and then we will answer it also in writing. So this is number one. We also have a chat function. If you want to tell us something that you need to convey, like a message or a feedback, or something is wrong with interpretation, this is where you would use the chat function, just for a comment that does not need to be responded to, or to report an issue, or to say thank you. This is the chat function that you will use. You press on the button and you see the chat field appearing here. Down below is where you type your message, and it will appear over here, like you see on the screen. So at the end of the webinar, before exiting, we will ask you to fill out a survey on exit. It's in Zoom, so you do not have to go anywhere. There are only 3 brief questions that we ask you to respond. How useful it was, how you liked it, and it's a very good sign for us whether we need to continue as we go, or whether we need improvements, or whether we need something else to be done. If for any chance you missed the survey and exit and you did not have a chance to respond to the questions, tomorrow you can send us an email. We will have a link in your email. In the email that we send to you, there will be a link to generate an email back to us that is called I'm satisfied, and you can send us that email if you liked the webinar, if it was useful for you, and you can include any of your comments in the body of your email. So the link will generate an email for you. The email will go directly to us, so it will have the address pre-filled. So the webinar, the training modules that we will be talking about today, they are located on the World Bank Group's Open Learning Campus, olc.worldbank.org. And this is where you can receive a certificate. We always have in the feedback that is sent to us, we always have a question about obtaining a certificate for participation in the webinars. Unfortunately, this is not possible, but if you go to OLC and complete one of our training modules and evaluate that module, this is a prerequisite, you will receive a certificate from the World Bank Group and the Open Learning Campus, the certificate for having successfully completed the course. And the name of the course will be there, and your name will be there. So this is where you receive certificates. You need to complete the course, and complete the quiz at the end of the course, and evaluate the course itself. Fill out a questionnaire, what was useful, what was not useful. Again, this is the OLC system that we cannot change, and it requires you to evaluate. So I'd like to present today's webinar and the speakers, and I pass the floor over to Julia. Thank you very much.
Thank you very much, Natasha, for your wonderful introduction. So good afternoon, good morning, everyone. Welcome to IFC series of webinars. And today we are happy to discuss the international patient safety goals. So what are international patient safety goals? Why are they so important? Why is it #1 standard in many accreditation systems? How well do we understand the international patient safety goals requirements? These are the questions that we would like to discuss today. All of us know a lot about all the 6 international patient safety goals, and I'm sure that this word combination you have heard many, many times. But how well do you understand it? How well do we understand it when we think about hand hygiene, for instance? Is it enough just to print out the WHO guidance from the website, put the hand washing guidelines near the sink? And does it mean that we are compliant with the requirements of the hand hygiene or not? How to identify patients properly, how to choose the right identifiers and not to make mistakes in that process. All of these questions we will be discussing today. Also, I wanted to stress once again the fact that you can ask our experts questions, and this is a unique opportunity today. If you already started implementing the international patient safety goals in your medical facility and something is not clear to you, please feel free to ask questions. Also, we are happy to announce the launch of our on-site learning modules. Natasha already described how to access them. After completion of these online modules, you will be able to get a certificate. And also, we believe that they will be useful for you. They are free of charge. You just need to access the link and register. And hopefully, they will help you implement the whole program and ensure full compliance. They have lots of useful tips, but we will talk about them later. Now we would like to move to our first speaker, and we are pleased to introduce Dr. Ashraf Ismail from Egypt, Chairman of the General Authority for Healthcare Accreditation and Regulation. Maybe you already heard the abbreviation for this is GAHAR. So Dr. Ashraf, the floor is yours.
Thank you very much. Good morning, everyone, all the participants. Good afternoon, good evening around the globe. It is really my pleasure to be with you today addressing this very, very important issue. And I'm sure everybody who is participating today and who will be watching this series is particularly interested in this very important topic, which is the safety and the application of safety around the globe. As we all know that safety has become priority number one long time ago. And there was a lot of talks, discussions, education, understanding around the globe about why patient safety is important, what are the elements in patient safety, what are the patient safety goals. And different countries took different avenues in identifying those goals. From United States Joint Commission that identified the national safety goals as 14 goals, which represent the most important events. And then the JCI, the international safety goals, different national also accreditation bodies around the globe that identified different numbers in different terms for patient safety goals. Like in GAHAR, for example, we identified more than 30 patient safety requirements, which are really representing the most important and serious issues that are facing patient safety. So I would say that there are different goals, but we need to realize that these goals are really goals, and what makes them happen are the plans and the real implementation for those goals. They are not just being implemented by adopting them or understanding them or considering them in our mind or in our documents, in our strategic plans. But what really makes them happen is the implementation of the plan that make them happen. And when we come to implementing those goals, ranging from all kinds of, we have plenty of those goals in different details and different dimensions. But when we implement and we start to expect the results, we find that this is very challenging. And the results sometimes are disappointing because we don't get what we expect from this implementation. The question always why, and whether those reasons and challenges are the same around the globe in different countries, in different settings, in different hospitals. We have to search and we need to understand what are those challenges that make the implementation of those patient safety goals happening. The reasons and the causes are so many, and they vary from place to place, from country to country, from setting to setting. So the deep understanding and the root cause analysis of this is very important so that we can address the right solution, given the fact that there is no one solution that fits all. There is no generic solutions for the same problem. And we will give examples of the issues that we are addressing today in hand washing, in patient identification, and other issues that we are addressing, that we will find out that there are many reasons for those problems. They vary from organization to another. So let us start by addressing those challenges, and this will open a lot of discussions for various reasons why we are not meeting and underlying causes of why not achieving what we wanted to achieve in patient safety. The challenges, as I said, are so many, and they vary from different categories, I would say here, and then we will discuss what in each category, and perhaps we can come also to what will be the solution. The first, actually, a big challenge in implementing patient safety will be related to environmental factors. And we will see how this environment can control the implementation of those safety goals in general. We have also the culture issue. And this proved in recent years to be one of the main reasons when the culture of safety is not there, or there, but we cannot not enforce it. We will see how those cultural issues are really affecting. There are many reasons related to the system, the processes, the complexity of those systems, and the underlying causes on those systems are so many. The resources and the resource allocation and how the resources are available, this is one major cause. Technology and equipment prove to be also a very big challenge. We are going to address and talk about how this represents a barrier towards patient safety. And human factor is a major cause, whether it is from the provider side or from the patient side. And finally, an important issue is legislations and the structure of legislations in different countries and how this affects also the system, and as related to the legal issues related to errors and the system related to patient safety. So if we start by the environment, we will find actually that the risk in healthcare is so many risks. The healthcare facilities is not a very safe environment by nature, due to many factors related to the technology we are using, related to the patients we are treating, related to the complexity of the operations, related to the nature of operations, the surgeries, the anesthesia, the kind of gases, the medications. So there are several risks related to the healthcare facilities, if we do not realize them, we cannot really address them. And related to this environment is the structure of the hospital itself and how the hospital is being designed and built to address those risks and make sure that the design is designed to be error-proof to prevent those errors. The design, in fact, in many hospitals around the globe has been built many years ago, decades ago, when the codes for building hospitals were not taking into consideration any measures for patient safety, which were not really well formulated in the last century. They have been, there is a lot of now evidence-based design, a lot of research that prove the direct relation between design and patient safety. Examples for this, let us think about hand washing and the availability of sinks around the hospital, where they are located, what kind of water splash they are using, the plumbing system that is related to this, whether they are outside the patient room so they can be used before entering the room, or they are inside the patient room, where they are located inside the patient room. The examples and the challenges are so many in this. Sometimes it's related also to water tanks, where they are where are they put in the design, where the flow of water inside the hospital, how clean is this water being used, and making sure they are not source of infection, etc., etc. The floors, if we are talking about patient falls and the design of the floors, how slippery they are, the kind of finishing they are using, whether we are using carpet, using marble, using any kind of material which really can be a reason for falls, the light itself and the distribution of light, especially at night with patients who are drowsy, who cannot really help themselves. And then when they usually fall, when they go to the toilet in the middle of the night. So a lot of issues related to design, if they are not taking into consideration those patient safety issues, it can lead to serious errors and serious problems and consequences. So definitely, when we think about that, there should be a lot of work to do about the solution about this is to realize how risky is the environment in patient care in different settings, and taking all this into consideration when we design the hospitals and implement evidence-based design when we are considering all those environmental issues. And this becomes a science and something that the whole world really should consider when we think about the highly reliable organizations. This must be taken into consideration in all our current work and future work. The culture. Culture is very, very important. It is the collective thinking of the organization and what are the beliefs that control what we are doing in our organization. Sometimes in many organizations we see around the globe, there is lost sense of responsibility towards safety. They don't know who is responsible. And they think sometimes that the security officer or the safety officer is responsible for safety. And they think that leadership is delegating this responsibility sometimes because it is not there in their radar screen. And this is transferred to the whole culture that they don't feel that everyone is responsible. And this creates a huge lack of responsibility and awareness around the organization related to the different roles. Leadership is not committed. This is number one problem. If leadership is not committed, they don't understand what they need to do about patient safety. Forget about implementing and enforcing any any kind of policies or achieving goals or anything, because everybody will follow the radar of those leaders, and definitely it's not going to be a priority if it's not priority for the leadership. The fear culture is a big enemy here, because if we do not report errors and we don't learn from mistakes, we will never know that there is a problem. And the biggest problem in patient safety is not to realize that we have a problem. There is a false sense of security, false sense that we are doing the right thing, false sense that this is what the best we can do. And this is a big barrier. And over and above, there is a fear factor from important people in the hospital or in the facility, fear factor from the surgeon not to report in the operating theater if we don't follow safety measures. So fear factors between the hierarchies in nursing or between nursing and the physicians. This actually a huge enemy of all issues related to safety. Definitely, we need to create this, the sense of responsibility, and everyone is responsible. This notion that we are using, we need to translate into real work and real action, real plans, and everybody get involved in the right way. Leadership is the key, and leadership has a responsibility, and most standards now address the direct leadership role in implementing patient safety, and there is no way that this can happen without the leadership. Creating just culture and creating the culture for quality and safety, everybody is responsible. And also, we are not really implementing the blame culture, which is very dangerous, but just culture that really makes people responsible, willing to report errors, and if there is a problem in the system, should be fixed and not always blame the person. However, if some people are reluctant to implement those rules and regulation for intentionally and violating the safety rules, there is no compromise here. And also those people should be really disciplined and should be following the system the right way. So the cultural issue are really, really key to this. When we come to system and the resources, we will find that the systems inside hospitals are very complex by nature. We are dealing with so many factors, variables, patients, diseases, providers, different schools of thoughts, different. So the system here actually should be designed addressing all those issues. And if the processes within the system are complex and people have difficulty to understand and comprehend them, this always leads to errors. So streamlining the processes is important, explaining it to the people and understanding those, adopting those processes, which leads to the policies, to the procedures and the policies that will be implemented. If they don't adopt it and implement it, we will always be in trouble with implementing this. The system itself should, if it's not designed to take into consideration the safety measures, there is no way that it will be implemented. The lack of adoption of the safety policies due to lack of enforcement and sense of irresponsibility, and also lack of consequences. People sometimes ask, what's going to happen to me if I don't do this, or if I don't wash hands, or I don't do patient identification every time? So there is lack of adoption due to maybe lack of enforcement of those policies. Staff are not trained sometimes. We get a lot of staff. We know all around the globe that we have shortage of healthcare professionals. So we should not expect that we always get the people who are competent, who are top notch, but those people always need training, and they need follow-up and need competency testing. And we need always to work on this because every day there is also new technologies, new systems that always need to be introduced, and people need to be trained on this. Lack of resources, we're getting surprised when we go and find in some hospitals there is no soap for hand washing, for example, or the gel is not there in the dispensers, or sometimes water is not available all around. Sometimes we don't have enough number of people to do the job, and the nurse has to be occupied all the time carrying things back and forth, and they don't have time to do certain things like washing their hands every time they get to the patient. So lack of resources, whether it's human resources or the materials we are using or the equipment we are using, the sterilization issues, all kinds of resources should be there in order to ensure that we implement what we plan for patient safety. Communication represent more than 63% of the problems and errors and patient safety. It happens because of poor communications between the providers, between the teams, in between the shifts. People do not write everything clearly. They don't communicate it clearly. So the handover and the communication between caregivers has been addressed in all patient safety goals. The teamwork and the huddles and in the operating theater, in the wards, it has become more and more important. Communication hierarchy between all the levels in the facility, leadership and staff. All the communication issues could be a big barrier if it is not well formulated. Definitely, we need lean strategy to address those complex processes and to streamline the process, eliminate all the unnecessary steps from those processes. Definitely, we need to embedding the safety culture and take into consideration all the safety measures when we design the processes. Engagement of different stakeholders in the process to adopt those processes, competency assessment all the time, allocation of budget and resources, and well-defined channels of communication across the levels in the hierarchy. Technology and equipment is a big issue because in many places also sometimes you have obsolete, unsafe technology. And the obsolete, unsafe technology in all aspects, in all the hospitals, in many hospitals, they don't invest in upgrading and improving this technology. This technology can be unsafe by definition, and the equipment are source of maybe radiation, source of infection, source of inaccurate results, all kinds of problems with obsolete technology. And people may keep them because they are comfortable working with them, they know about them, but they are not safe. The opposite happens also with modern technology. Modern technology, sometimes we get very high tech pieces of technology, but we don't place them in the right way. We do not really do the protection for them. And our colleagues in radiation and radiation safety, they know the hazards if we don't do that for imaging and radiation technology, for example. And in all kinds of technology, even simple pieces of technology, if they are not introduced well, we can have a lot of problem because we do not really train people and introduce it well to everyone. Inadequate training for this proper technology and unawareness of the importance of periodic preventive maintenance and calibration. Definitely adoption of new technology and safe technology practices is very, very important for safe technology, planning for technology placement, competent staff and their training, and inclusion actually of the preventive maintenance and the calibration for all kinds of equipment. Human factor is a huge issue when we talk about the provider and their competences and their attitude and the behavior and the role model they play to each other. Like in hand washing, for example, we found that if the doctor do not wash their hands, people follow the pattern of this doctor, believing that he knows the best and we don't have to wash our hands every time getting in and out, seeing the patient, etc. This is a huge problem. So service provider, if they are not motivated, not trained, not educated, can be a big, big issue. And then the service recipient, the patient himself or herself, and if not empowered to ask a question, for example, about patient identification, sometimes they cannot ask who you are, and the people are reluctant to introduce themselves every time they see the patient. This also can create a lot of problems if the patient is not empowered to speak up and to be part of the system for patient safety. Lack of education of service providers and lack of supervision, weak disciplinary actions regarding reckless behavior, and there is no consequences, so they don't care, and this is a very big issue. Work overload, if they not enough number of those, and lack of rest, and all these are factors which really affect the sleep deprivation, overwork, the low morale in the workplace. All these are directly related to patient safety issues. There's a lot, of course, of actions to be taken in order to reverse all that and to make sure that the service provider are responsible and the recipients also are those who are vulnerable. Is patient engagement, patient education, and their empowerment is very, very critical. The last part here we are going to address is legislation. And in many countries, there are issues related to medical practice, errors, how to treat with that, and the consequences of poor performance, whether from the legal aspect or also from the financial aspect. And now there are adoption of no pay for poor performance, like if infection happens because of some hospital-acquired infection due to lack of hand washing or whatever, or lack of sterilization or bad practice, surgical site infections. Many systems now, they do not pay for any extra stay or extra treatment or for those. If the patient fall during the stay and they have to stay for another 3-4 weeks to be treated from the fall, this actually is not going to be compensated. However, it can lead to legislation and sue the hospitals and may lead to very big punishment and penalties to the hospital. So the legislation here, if taken into consideration, either people understand the consequences, I think this is an important issue. If this is absent, I think this is going to be a barrier, because people would not really appreciate the work and the investment to be done in safe practice. At the end, actually, I would say that unless we do real performance improvement methodologies to address patient issues, we might not get good results. And many of the current improvement methods proved not to be effective. And we can discuss this in more details, but definitely we need to adopt robust performance improvement methods which can bring real effect. The last thing here, this is example of a target solution tools that was done specifically for hand washing by Joint Commission in the Center for Transforming Healthcare, and they found very amazing results. There is no one one size that fits all. Problems vary from place to place, from organization to organization, and the solution, unless they are really tailored to address those deep issues, usually there is no good results. So this is again something we can discuss in details, because we need to get into the depth of those causes to get results. Thank you very much, and looking forward to more discussion during this webinar.
Thank you so much, Dr. Ashraf, for your wonderful presentation. We already received feedback in the chat that it's very well articulated and very clear. So thanks a lot for this clear presentation, because I think that understanding the key principles is one of the most important things in healthcare quality. And this knowledge is something that we all lack. We all lack clear explanation of the requirements and clear principles. So thank you very much for this. And before we move to the next speaker, I just wanted to sum up a little bit of the key points of the presentation of Dr. Ashraf for those who joined a little bit late, because I saw some participants were joining late. So no one size fits all. Even for such obvious things as international patient safety goals, the requirements need to be adapted to the local specifics for each country and for each hospital in particular. There will be specific gaps, specific culture in this hospital, and all of this needs to be considered. And that's why we developed our modules. And also, let me remind you that today we are talking about 3 international patient safety goals, which relate to the identification of the patient, to the prevention of falls, and to the hand hygiene. And there will be a second session, and we will send a separate invitation for that, separate webinar on the other 3 international patient safety goals. So we need to adapt all the requirements, and for the identification, for fall prevention, and for hand hygiene, we developed our online training modules, and there we explain the approach. We give lots of tips, lots of checklists and scales, and lots of techniques that you can use in your hospital, thus adapting the requirement to your specifics. And also you can adapt when you understand the whole picture, and this is something we try to address in our modules. So the second point that Dr. Ashraf made is that there are multiple components under each of the international patient safety goals. And as I said earlier, printing out the WHO guidelines is not enough. Even just training your staff is not enough. Leadership support is not enough in itself. There are multiple components, and they only work when they come together. And again, I would like to refer to our online training modules. You will find all the components required, described in detail in those modules. And the key point in Dr. Ashraf's presentation was that there are also components that many often forget about. That is, for example, role of the infrastructure. Strangely, this is also the fact that we find when we do our assessments with the IFC tool, infrastructure is often neglected. Many quality teams just forget about assessing the infrastructure, even if they are assessing patient for the risk of falls. While such things as bed height, for instance, or slippery floors or unnoticeable steps, they play a huge role. Or, as Dr. Ashraf mentioned, key factors that will make successful implementation of hand hygiene is, first of all, availability of the sinks in the right place and availability of water. And again, what many medical facilities forget about the role of the infrastructure in hand washing, and we come and we see empty soap dispensers, or we find no sink in the required place. Of course, in such facilities, in such conditions, we cannot expect full compliance. And now let me pause here. I would like to give the floor to our next speaker, Joseph Williamson, part of our IFC healthcare quality team, but also a maternal fetal sonologist. Joseph, you're welcome.
Thank you, Julia. Can everyone hear me? Good. Okay.
Yes, all great.
Share my screen. Okay. Good morning, good afternoon, good night, whatever time zone we find ourselves in. I just want to welcome everyone and say how actually very, very fortunate I feel and very privileged I feel to be taking part in this, because this international patient safety goal initiative that we've taken on is a huge, huge thing, very huge thing. And it's funny because I often dread going behind a speaker that has been so well versed as my colleague that has gone before me, but I feel like I could actually probably close off the session and not say another word, because he's pretty much encapsulated everything that we should be thinking about when it comes to international patient safety goals. Here's the issue with international patient safety goals. There are so many layers to it, and it gets so astronomically complicated that I think that's why we have such a hard time closing the gaps in some of them. So when we look at something as detrimental as patient identification itself goes across every facet of our patient treatment, from radiology to lab, to checking the patient in, to discharging the patient. Every single part of the hospital gets affected by patient safety, by patient identification, I'm sorry. And so then, as Julie has said, there is really no one way of making sure that patients are identified correctly. Do you have a process to do that? And I think as we go and we assess hospitals and we look using the IFC tool at different hospital processes, we find out a very not surprising thing, that every hospital may have a different way of doing it. That doesn't mean that it's wrong, but what it means is that it allows us to broaden our view and make sure that we don't think that one way is the right way. Now, we've assessed hospitals, and I've been in and out of hospitals for the last 32 years. And one thing that's always common, and I think my colleague touched on it before me, is we always think, a lot of hospitals think that they're doing it right. If I ask a hospital, how do you identify patients? Do you have a good identification process? A lot of hospitals will tell me before I start looking at them that yes, we have a very good hospitalization process and identification process. And then once we actually start looking at it, we begin to find some gaps that we can definitely identify. So I would actually admonish everyone to go on the IFC website, the World Bank Open Learning Campus, and actually take the course on patient identification and see exactly where your gaps would be and how you can actually improve that. So patient identification, it becomes very, very important to us, because we now know that patient identification incorrectly can have a large ripple effect through the hospital. We have wrong procedures being performed. We have procedures that are performed on the wrong patient or the wrong side. We have medical errors. We have, even when we go to our lab, blood transfusion errors. And what we need to realize is that these can also cause sentinel incidents and sentinel accidents. So it's important to mention that these mistakes often harm two or more patients. For example, if I identified the wrong patient, a lot of times the patient that was supposed to be getting the blood transfusion or getting the medication also gets affected. So the World Health Organization has a surgery safety checklist. They have identification checklists. And as Julia said, it then becomes important to realize that it's not just a matter of downloading those checklists and plastering against your hospital wall or your facility wall. Basically, how do we implement that? How are these things implemented? There has been a lot of studies, and I'm not the kind of person that likes to go into 15 different studies and pull out all these bar charts and go, but there's a very interesting study that was done by a worldwide organization that undertakes medical healthcare investigation. And what they found out is that a lot of times when we're talking about, my slide is not advancing. Yes, a lot of times when we're talking about patient identification, we forget that a lot of patients slip through this identification crack. So in 2015, a study was done in the US using 181 healthcare organizations. Those 101 healthcare organizations were asked to send in their wrong patient events, okay? So out of those 101 organizations, they sent in over 7,000 cases that were wrong patient events. And it's very interesting to note that 2,000 of those cases, over 2,000, 37% of those cases were involved in the diagnostic procedure realm, which means radiology, laboratory, phlebotomy, all those things that diagnose the patient while the patient doesn't even have to go anywhere. They can actually come to the patient's bedside. We're involved in these wrong procedures. So what does that tell us? And we'll address that a little bit further. 72% of these failures occurred during encounters with the patient, which means somebody was talking with the patient or somebody was handling the patient and mislabeled the patient or gave the patient wrong identification. And then going on, 1,700 of these patients were treated wrong. In this study, they actually had 2 deaths because of wrong surgery. The wrong patient was entered into the wrong surgery. And I actually put the website that you can find the study because I thought it was a very disturbing study to me. So patient identification errors have been around for a long time, but as we look at them, what are the gaps? What are the challenges that we find in patient identification? And we could say that, when I started practicing medicine, there was no electronic medical health record. There's very few of that. So when we instilled electronic health records, we said, okay, this is going to improve the way we identify our patients. This is going to get rid of those identification errors. And what we found is that we still had human error. We still had patients that were not identified correctly because we still have a human error factor in there. So what are the common gaps? What are the common problems that we find when we have to identify patients? Well, we have inconsistencies. If I go to 4 or 5 different hospitals that are not accredited, they may have 4 or 5 different ways of identifying their patients. Now, it doesn't mean that they're wrong. It just means that now we have to look at that a little bit more carefully. And so what I found is that as I went through the hospital, maybe lab would identify their patients by one set of identifiers, and I went to labor and delivery, and they identified their patients by another set of identifiers. But the problem with that is when those patients were moved from lab to labor and delivery, there was now a breakdown of communication of how these patients were identified. And my colleague before struck on the nerve of communication. There has to be communication in order to make sure that these international patient safety goals do not slip under the wire. Another important aspect of patient identification that we find that slip through the wire is the transfers and the handoff. I take a patient from the emergency room and I take them to radiology, okay? Is the identification safe when they get to radiology and when they come back? And it's funny, I went to one institution and I saw them take the patient from the ER and take the patient for a chest x-ray. Now, you and I have both been in the ER, the accident and emergency, you have a line of beds sitting there. Patient gets taken, another patient comes and fits into that slot. And I noticed that. And I said, well, when that patient comes back, how do you make sure that that is the right patient that gets back into the right bed? And they said, well, because the bed number, we know the bed number. I said, well, that's not an identifier. We know that WHO and CDC and all these facets have said we need 2 bed identifiers and they don't need to be, okay, the patient's room number, okay? One of the big things that I found is that sometimes we do not involve the patient in the identification process. There are several places that the patient could actually help you know that you're making a mistake. Most patients know who they are. And sometimes when we do timeouts in hospitals or we're getting ready to do surgery, one of the biggest things we do is we say, okay, Mr. and Mrs. Smith, what surgery are you here for? And that patient, 9 times out of 10, can tell you, I'm here for X, Y, and Z surgery. Or we can ask Mr. and Mrs. Smith, can you tell me your name, please, your full name, complete name? And that patient will tell you your name. But what I found is a lot of times that we do not incorporate this into our patient ID process. Also, what we know is that a lot of unresponsive patients get misidentified. Patient comes in, the patient is unconscious. How do we identify that patient? Sometimes before the patient gets their stamp on, okay, or their wristband, that process has already started. And then we have a big one, which is the interdepartmental communication. If my patient is going from the laboratory to radiology, is there a communication between those 2 departments that says, hey, this patient is going here, expect him here, he's going to get this test, please call me when he comes back. In our hospital, we instituted something that actually helped reduce this kind of mistake. What we did is when the transporter or the porter came to pick up the patient, the nurse that released the patient would send a call to the nurse where the patient was going. And that nurse would know that Mr. or Mrs. Smith is coming here. And so they would check the band again while the patient got to the department and before the patient got whatever procedure they were getting. So, you can start to see that this is a complex situation. And why don't most departments have a patient identifying a common goal is because it is very complicated. And the last one we have is that staff is multitasking all the time. We find that we have, as my colleague said, a very, very big lack of medical healthcare workers. And therefore, the patients are crowding, the patients are coming in. As the staff gets more busy and there's no standards process, then it becomes very, very difficult to keep track of patients. Identifying patients using a room number, a bed location, or a diagnosis, basically, we have 2 identifiers that we must use. Now, some hospitals use 3, some hospitals use 4, but at least 2 identifiers must be used. And it must be consistent. It must be consistently used. Same identifiers. So healthcare organizations have an explicit process in place, most of us, to correctly match patients with the intended care so that the right patient receives the right care. When does that start? What we found is that, that patient identification mistakes sometimes happens before the patient gets to the hospital. The receptionist picks up the phone, this patient is coming in, she does not ask sometimes the right question, the patient comes in, and sometimes what we found is that that patient is misidentified before she even checks them in. Now, the pre-admitting communication is part of the interdepartmental communication that we're talking about, and so is admitting. And so we have things like the patient is getting, bedside phlebotomy, the patient is getting their blood drawn, the wrong tube is labeled, the patient is going for interdepartmental testing, the patient's identification does not follow that patient. One of my biggest, and I'm not afraid to tell you this, I'll be perfectly transparent with you, one of my biggest mistakes was in rounding. We're all clinicians, we're rounding with the patient. We got a group of clinicians in the patient's room. Somehow the patient's chart has been left on the bedside. I pick up the chart and I start reading through the rounding. Halfway through the chart, I realized, wait a minute, this is not the right patient's chart. But what I didn't do is before I started even reading the rounding notes is look at the patient's wristband and match it with the patient's chart. So these are things that we can do over and over again to make our job of patient identification much easier. And also patient transport. When that patient gets transported again, whether it gets transported to the ambulance or gets transported to another department or transferred, then we need to make sure that that identification process follows the patient. And then lastly, discharge. We find that even in discharge, the patient can be misidentified. I've seen patients that they're getting ready to be discharged and the wrong discharge medication is sent home with the patient because no one checked the medication against the patient's bracelet before they took them in. Okay, so post-encounter, basically, the referrals, the health information exchanges, electronic prescribing, all those we need to keep on top of to make sure that when we do that, the patient's identification is still set. Just a quick question then. If we look at this chart, where do you think, in looking at this chart, and you can either type it in chat or keep it for yourself, where do you think most of the patient identification problems happen? We have registration here. We have the patient going to diagnostic imaging and pathology for laboratory and diagnostic testing. We have patient treatment, which includes, again, transfusions, cath labs, specialized procedures. We have the visit when it's completed and the patient goes back to their room for monitoring and documentation. Where in this whole scheme of things do you think that it is possible for patient identification errors to happen? Well, the answer, and I'll give it to you real quick, is anywhere in this journey that patient could be misidentified. And this is why we need departments to be one-on-one with each other, interdisciplinary, and we also need them to communicate with each other about who this patient is before this patient gets there. And I will remind you of something that I said, ask the patient. We instituted this in our hospital simply because there are some patients that won't talk to you unless you talk to them. The patient knows themselves. The best way to ensure that the correct patient's in front of you is to ask that patient if they are lucid and if they are speaking your language, of course, but we have translators for that. Use an open-ended question when you're asking a patient. Like, don't say, Mrs. Smith, is your first name Mary? This usually throws the patient in, and if you have a confused patient to begin with, they'll probably nod at you, you know? So use an open-ended question along, and then along with checking the ID band, check everything else around the patient also. Prior documentation of that patient's identity and confirmation at every stage of the clinical handover is vitally important. So identification tips and must-haves, okay? What do we learn? What do we learn from this? Well, we have to specify the process for correctly matching patients to their care. And in international patient safety goals, that is a big thing. Do you have a process? Is there a process? For whatever we're talking about, we need to ask ourselves, whether it's hand washing, whether it's identification, whether it's patient falls, is there a process set in place? Because a lot of facilities do not have a standardized process. That's the first thing. The second thing is that process documented? How do we know when we make a mistake? How is it documented? Is there a system that we can go back and look at that documentation and say, hey, we need to do better the next time? I can actually tell you that one of our best systems that we put in place is rounding with each other and rounding with the patient. Every morning, 8 o'clock, before we get started, we pull the patients and say, hey, here are our patients for the day. What is this patient's name? What are they here for? Let's make ourselves familiar with this. Healthcare organizations, they must have an explicit process for doing this. And so the must-haves from this, the policies and procedures that have to be in place outlining where and how to document the information that you're going to get. Remember, if it's not written down, it never happens. So the must-have is you must have the documents, you must have identifiers on the patient's bands or the patient's identification. Every step of that patient's journey through the hospital should be documented for clinical handover, and you must have an ongoing process and a tool for auditing that process. That's another thing. If we could have the process, how do we know when the process is not going correctly? We have to audit that process, okay? It's critical to know that both medical professionals involved in checking the identities of patients and using 2 or 3 identifiers, if you do that consistently enough, it becomes habit. And if habit is done consistently enough, it becomes what Dr. Ismaili said, culture. It turns into a culture. Does the hospital have a culture to make sure that mistakes are kept to a minimum? Or does the hospital have a culture, well, let's go a step further, to make it a 0 mistake hospital? What's the culture in the hospital? Okay, so that becomes very, very important when we talk about the patient identification. It flows, that same culture flows into when we talk about patient falls prevention, okay? To prevent my patient from falling, there has to be a culture going through the hospital that says, I must have 0 falls for this month. And most hospitals that actually get this right, you see their auditing process is 0 fall process. They have universal patient precautions, okay? What's the falls risk precautions? How do you prevent falls in your hospital? Well, if you take a moment to realize that falls is just not one department's responsibility. If the nursing department says, okay, we want to prevent falls in our nursing department, let's say in our intensive care department, we want to prevent patients from falling, or better yet, in our labor and delivery department, that is just not one department's access to that, right? Because that now mushrooms into the other departments in the hospital, and we'll talk about that in a little bit more. Again, going back to the modules for the IFC, false risk and patient safety is a very important one, because it basically is going to help you, if you go through this model, establish a false safety program and a false safety infrastructure. And as Julia said, one of the things that we find when we go to facilities is there's no infrastructure to build on, right? You can't have a false risk safety program if you don't have the infrastructure on which to build that program. And how do you promote the fall prevention for patients, for staff, for visitors? And very important, for visitors. We have to remember that we are going to have some visitors to come in that we're going to have accidents with. How do you promote falls risk safety for those visitors? And how do you monitor if those things are safety or not? What are the common gaps that we go into hospitals and see in falls? Okay, well, if we talk about falls risk, and if you ask a hospital to say, hey, I need you to put together a false risk program, that is not an overnight thing. A false risk program is a very complicated program. And that is why most hospitals that I go to evaluate in other countries do not have an active false risk program. Now, they may have one or two things that they said, oh, we're going to put a bracelet on the patient to tell you that it's at false risk, or we're going to put some, strips on the floor to make sure that patient doesn't fall. But we find that those are haphazard things. They have not gotten together and brought all those things together and say, what is our false risk safety prevention program? And how many departments do we have to involve in that? So some of the common gaps that we find is that, well, first of all, there is no false program. And if there is a minimum false risk program, there's no patient assessment. We know that the program is designed to raise the participants' falls prevention knowledge and awareness. But if there's no way to assess your patient for falls when they come in, you really have not done a good falls risk program. So there is no assessment of patients. There's no environmental department cooperation. What do I mean by that? Well, here's the thing. If I have a false risk program and the environment of my facility does not conduce itself to preventing patients from falling, then I have a problem. We've seen that there are steps down from the patient room. We've seen that where the patient bed is nowhere accessible to the bathroom, okay? We've seen that when the floor is mopped, it is so slippery that even the people that are mopping the floor are walking around careful, but they do not have signs. All those things are common gaps that we've seen when it comes to environmental department cooperation. The other thing that I noticed is a lot of times there is no patient-provider communication, okay? Patient to provider communication. What do I mean by that? There's no education of the patient. When I come in as a patient, what I've noticed in the best facilities that I've been in is if I come in and I'm a patient, I'm getting a test, whether it be inpatient or outpatient, they explain to me, sir, we do not want you to get out of bed unless you call a nurse. Sir, when you get out of bed, please make sure you have your socks on, okay? There is communication and education between the provider and the patient. But if there's a lack of that, the patient just does whatever they want and they get off the bed. And a lot of times they do fall on their way back and forth to the bathroom. One of the most interesting things that we did in one hospital that I worked at years and years ago is we actually had a falls program and they educated the staff on what it means to have a falls risk assessment program. So you know what we did? We dimmed the lights in an empty patient room and we took the staff into that room. And we actually told the staff, I need you to walk from the bed to the bathroom without turning the lights on and then walk back. And we put obstacles in the way in a very dim room. Of course, you know what happened. The staff stumbled and fell. Now, we said, imagine you're a patient with poor eyesight and poor mobility. What do you think is going to happen? We had environmental services there and facility service there too. And so what happened is as we mapped out that path from the bed to the toilet, we realized, okay, you know what? We have to get facilities in here. We have to put handrails on the walls. We have to put no strip. We have to make sure that every nurse knows that the bed needs to be lowered all the way before that patient gets out of the bed. We have to make sure that every technician knows that the rails have to be raised after they finish treating the patient. It became, we actually saw in our audits where our patient falls went from here to here because now the staff understood. They had been educated. They knew now what it was dealing with because they were now familiar with the process that the patient had to go through, okay? So another thing was that the patient, what we found is when our falls risk went down, when our falls to our patients went up, is because there was no quick win implementations. What do I mean by quick win implementations? I mean this. If we find the hospital cannot do a full falls risk program because they don't have the staff or they're too crowded, there's some very quick wins that they could have done. Patient fall socks, non-slip strips across the floor to make sure that in their policy and procedure, as I just said, is the policy to say if a nurse is dealing with a patient and getting the patient out of bed, the bed has to be down to the lowest rung if it's an automatic bed before the patient gets out, or the rail has to be back. And I can tell you a horror story from my end where I actually treated a patient, talked to a patient and forgot to put the rail back up, and the patient was inebriated in the ER. And they fell out of the bed and had to be taken to CAT scan to get a head CT. Now, I wasn't thinking after I finished the patient, put it back up. Those are some very simple, quick wins that we can install. The last thing is one of the common gaps, and one of the common gaps I notice over and over again is that most hospitals do not have a universal fall precaution. Most of the ones that we see, there's no poster in the hallway to educate about what is universal falls precaution. And so it doesn't have to be a full-blown fall prevention program, but there should be some universal things that that hospital or that facility is doing to prevent. Again, I mentioned some of them, some simple ones like handrails, for instance, like making sure that no patient gets out of their bed by themselves, like making sure that all the pull cords are working for the patient alarm system. You cannot tell how many times we've gone into hospitals and the pull cords are disconnected or broken or does not work. Yes, the falls risk is a complicated program. It needs to be audited. It needs to have every single department buy into that program. So we cannot have just the nursing department without the facilities management, or we cannot have the facilities management without engineering making sure that every piece of equipment that doesn't need to be in the hallway in a patient's way is moved out of that hallway. And for patient education, basically, we need to relate to our patients that 1, they need to wait for assistance. 2, do not walk in your own socks. We won't allow you to. 3, look around you when you walk. And 4, go slow. Those things I found in hospitals with universal precaution are printed in the patient's room. And the patient that is explained by the admitting nurse when the patient is admitted to the hospital. Okay. So how do some of the best departments do this? 1, they familiarize the patient with the environment. They tell the patient, look, here's your room, here's the bathroom, here's your sink, and they walk the patient around the room. I've seen nurses do that. Okay. The nurses even demonstrate where the call light is. Here's the call light. Here's the cord you used to do it. I will come within X amount of time. They make sure that the call light is within reach. One of the hospitals I went to, the patient's bed is in the left side of the room, and the call light was all the way over about 5 feet from the patient's bed. So the patient would have to actually reach to pull that and could fall out of bed. Keep the patient's possessions within their reach, a lot of those things. Keep the wheelchair locked. Those are quick wins. Non-slip surfaces, using lights at night lights for supplemental lighting in case the patient needs it. Keep the floor surfaces clean and dry. Patient's care area uncluttered. These are all things that we could do as quick wins to make sure that the patient does not fall. This is, I had the privilege of doing some intern work at Brigham's Women's Hospital, which is a maternity hospital in Boston. And this is what their nurses and their techs use as a checklist for falls risk. Okay, not a falls risk program per se, but it was in every patient's chart. And the nurses went over it, the technicians went over it, whoever transported the patient had to cross off that they actually looked at that. And that way they became familiar and they knew basically that this patient was at a risk for falls. So here's the thing. Does your hospital develop and implement a process to reduce the risk of falls? And is the outpatient patient population part of that? Because we often leave outpatients out. One of the biggest falls risks that I've noticed in outpatient hospital is labor and delivery, especially in late stage pregnancies. Patients come in, they're hypotensive to begin with, okay? They're sometimes on medication, they're pregnant, they can't see their feet, and they fall, and there's no provision for this. Okay, so make sure your hospital also pays attention to the outpatient population. This is a huge, huge thing. Okay. And this is not, I put this up as a friend of mine sent this to me. We can't always make sure that our patients are 100% safe. Okay, but we can choose the right methods, the right processes. Okay, choose a process that works for your hospital. Choose a process that you can easily communicate, a process that you can easily standardize, okay? And make sure that that process is audited routinely, and you take the data from that audit and learn how to make it better. There's no one way to do it. And we don't all have it right. Even the best hospitals in the world audit their process. I went to the Mayo Clinic in Miami, and they're always auditing their patient falls processes, always making sure that they're doing best clinical and best evidence practices, okay? So, and I'm going to skip this slide because I think my colleague Faith is going to talk about it, but basically, how do we sustain effective fall program? We figure out who's responsible for sustaining that, and the answer is the whole hospital is, okay? We continue to monitor the fall rates. We continue to put interdisciplinary people together and continue to reinforce for desired results, and continue to make a culture a culture that is cohesive to false programs or to false risk or to prevent false risk. And this little poster here just shows that it's going to take a village in the hospital to come up with any kind of decision. It has to be a coordinated effort. Okay, so let's move on to our last thing, which is, and I'll go through this very quickly because we will touch on this later, is hand hygiene. Now, we know that infection control is one of the international patient safety goals, and hand hygiene should be the easiest thing to do. It should be the easiest thing to do, but we find that although a lot of hospitals, the good news is that a lot of hospitals are actually making sure that people wash their hands. But again, as my colleague said before me, there are still some gaps in the hand hygienes. And again, going back to the IFC training module, we know that there is a huge importance placed around implementing a hand hygiene program. Again, whenever you talk about programs, hospitals looked at me and said, you know what, that is too difficult. I can't do this. Can't we just put some things in place to make sure people wash their hands? But we find, again, that those things are not significantly consistent. What are the requirements? How do you engage your staff? How do you measure if somebody actually washed their hands? We had one hospital that actually brought an infection control specialist in with a black light and showed on people's hands where the germs were and how the hand washing were ineffective. And it wasn't just about downloading the WHO 5 moments of hand washing poster. It was making sure that people actually wash their hands. And how do you do this? Okay. Basically, we know that, as this poster said, nurses, clinicians, physicians, we work maybe 12 hours a day and 4 hours caring for patients and 8 hours washing their hands, right? That is maybe not identically good, but again, it is probably a little accurate because most of the times we were washing our hands constantly. There's a, I think it was a Canadian study that was done on hand hygienes, and it said most healthcare providers believe that they're already practicing appropriate hand hygiene. How many do you think that are actually practicing it? There was a question. How many health workers do you think actually practice in Canada, and it was a Canadian study, good health hygienes? And can you guess the number for me? Is it 95? Is it 10? Is it 40? Or is it 65% of health workers actually perform good hand hygiene? And I'll give you a second. Just think about it. Just type a number into the chat and let me see what you can come up with. Okay? Is it 10, 40%, 65, or 90%? I can tell you that in our facility when I was in the US, I thought it was 95 because I washed my hands and I assume everybody else did too. Okay, I actually thought we were at 95%. But when I was looking over this Canadian study and it was kind of equal to our hospital, the Canadian study at the end said, guess what? It's 40%. So less than half of us in facilities, in medical facilities, actually take part in good hygiene. Less than half. And that to me was a little disconcerting. I mean, we have the hand hygiene posters. We know that we're supposed to do this 5 moments of hand hygiene, but sometimes that's just posters. How do we actually implement it and what are the challenges? Well, again, going backwards, we know that the challenges to all the international patient safety goals is lack of standardization, okay, and a lack of team approach and a lack of leadership commitment. Leadership commitment is a huge thing here because leaderships are the actual force behind the culture. We can't build a culture of hand hygiene in the hospital, as our colleague was saying, if the doctors aren't washing their hands, if the clinicians aren't washing their hands, if the patients are watching, and they are watching, because you see it in the patient surveys, that they say, you know what? And I actually had a survey that said this in my department, such and such a person came in and they didn't use the hand sanitizer when they were examining me. Okay, to me, that's a big ding because it means that we are not training the patients right and the patients are watching us all the time. So those are the challenges, but what are the gaps? Well, why do we have these challenges? Because there's no education program or science, right? A lot of hospitals, when we go, they have insufficient signs. The signs are not just for the staff though, the signs are for the patients. We find that if we hang signs in the patient's room, we tell the patients to wash their hands, we give them pamphlets about washing hands, it becomes theoretically over and over, it becomes really, really a habit for them to do it, okay? Not only there's no education program for that, but there is no audit of hand washing. That's a big one, audit of hand washing. You know what? That is probably one of the biggest things in hospitals that I see is there's no hand washing audit. Well, how do we perform an audit? Why do we perform an audit? Why do we need to? Okay, that's a lot of the questions that we get. And a lot of hospitals will look at us and look at me and say, well, we wash our hands, we make sure our nurses wash their hands, but do we really have to have a whole program designed on actually watching people wash their hands? And I would say the answer is unequivocally yes. We do have to do that. Okay, so how do the best departments and facilities make sure that hand washing is a thing? Make sure that they're improving their hand washing? Well, it's a couple of things. It's not just one thing, right? First of all, what I found is the best facilities ensure easy access to all the hand rubs and alcohol-based thing. I had one hospital tell me that one of the reasons that the nurses and actually, no, it was the technicians, because they're in and out of the patient's room, don't want to wash their hands so often and don't want to use alcohol because it dries out their hands. I said, well, that's easy. We put lotions up right next to the hand washing alcohol-based rubs. That would be an easy solution. And so what we find is a lot of the hospitals that are really, really big on improving their hand hygiene will have lotion and alcohol-based hand rub. Okay, they provide ongoing education to the healthcare workers about hand hygiene techniques. So that means they have rounding where they educate the workers. They have town halls where they talk about this. It's active communication over and over again. Okay, they conduct research and they conduct routine observation of people washing their hands. And that could be the most tedious thing. I know it's tedious because I've done it. I've actually had to sit there with a clipboard watching people going in and out of rooms, but that is the only way to put together a program like that. And the only way we're going to the data, we need to make sure that people actually wash their hands. We educate the patients, as I've just said, and we use motivational activities. So we get our staff involved in motivating them to wash their hands. And that's a huge thing, is staff involvement, really huge thing. Standardization of the whole process then. We make sure that there are hand washing stations outside the room, inside the room, by the patient's bed. Every time you have to treat the patient, you shouldn't have to reach but a hand's length to get hand washing equipment, whether it's a sink or whether it's alcohol-based rub, it should be right there, okay? Right there. So basically, it's all about standardization. Reminders have a modest but a sustained effect. We can remind our staff, but it's not going to be sustained, not for long. We have to practice it and we have to make it standard. And we have to make sure that it's a multifaceted approach, more than just a marked poster on the wall or a marked standard. It has to be multifaceted. All the departments have to come together and say, hey, we're going to reduce our HAIs by routine hand washing. Okay, so it's just a little bit of tips for you. Compliance, communicate with your staff. Okay, choose the areas. If you're going to audit, choose the areas to audit. You can't audit the whole hospital. And we find that sometimes too much is just as bad as too little. Hospitals don't have an audit and some hospitals are auditing too much. In other words, they're trying to take on too much without evaluating the data first, without making sure that everything is compliant with one department before they move it to another department. And like I said, there's no easy way to do this. And then observe your staff. So lastly, last slide, what I want to institute with you is it's about culture, people. It's about culture. We had, and this is going to sound very funny to you, when we had to learn culture, we had Disney come in to teach our hospital culture. Walt Disney World, we hired their consultants to come in and teach us about culture. I was the biggest pushback on this. I said, I don't need to learn from Disney. I'm doing patience. I'm not going on a roller coaster ride. But you know what? Disney has it correct. Because when you walk into Walt Disney World, it's all about the culture of Walt Disney, and every employee knows that. Focus on culture, focus on change perspective, create a consistent message with your employees and measure the processes to be able to fix the mistakes and focus on the efforts of standardization. Thank you, and back to you, Julia.
Thank you so much, Joseph. This was another wonderful presentation for today. And we have one more. And that's why I wanted to say that our session was scheduled for 1 hour and a half, but it's such a hot topic, such important topic, international patient safety goals, that we definitely stay longer today and hope you find it interesting and you will stay with us as well. For the question and answer session, we will definitely have time and we will stay for additional time today. So please, if you are available, please stay with us. So before we move to the next speaker, I just wanted to sum up a little bit. Joseph made excellent point that all the international patient safety goals and specifically fall prevention, identification of patients and hand hygiene that we are covering today. And we will cover the additional 3 international patient safety goals in a separate session next time you will get the invite. So all of these are so complex. They are so complex that there are multiple areas where you can make a mistake, where every medical facility can make a mistake once they start to implement these requirements. How to choose the right identifiers, how to make staff interested, how to create the right culture, how to make sure that staff are washing hands properly when nobody's watching, how to use the right sink, how to choose the right tap. Is soap bar allowed or not allowed, or should it only be liquid soap? When to wash hands and when to use sanitizer? Lots of questions you can ask yourself. So all of these questions we address in our educational modules. In our chat, we get today very quick reaction to our presentations that they are useful, but you will find our modules, we believe, even more useful because they have lots of checklists, lots of tips, based on the common gaps that we observe in the hospitals and based on the experience of the team that developed the modules on the journey of their own implementation of international patient safety goals and the difficulties they had. So important thing about the modules is that once you finish the learning, you get a certificate, and this learning is free of charge. Not only you who are today the attendee of this webinar can have this educational module, you can invite all your colleagues, and this will help you to create the culture. This will save your time for the explanation of the key principles. If you are a quality manager, if you're a chief nurse, encourage your staff to use the modules because everything is explained in a straightforward way there. And as Dr. Ashraf said earlier, the requirements should be straightforward. If the requirements are complex, if nobody sees the full picture, it's almost impossible to implement, to create the culture and to implement the program in a full way. I'll pause here and move the floor to our third speaker for today. It's Faith Muigai, CEO and founder of Bridgewell Health. Faith, you're welcome.
Thank you, Julia. And it's very difficult to go through, go after the two presenters, Dr. Ashraf and Dr. Williamson, because everything I think has been sort of explained. I'm just sort of going to try and sort of come in from a user standpoint, have an overview, but give some examples of things that I've encountered. I've been a clinician, but then also a healthcare administrator for the last 20 years in the US and then in sub-Saharan Africa. And when Dr. Williamson is talking about some of the things, Brigham's, I actually was trained there, and some of the things he was talking about, I actually went through that. So it's very interesting to see how we're trying to bring those cultures here and trying to understand how we make them work here. Because when I talk about sub-Saharan Africa, we actually resist and we say it does not work. These are elements that happen elsewhere, whereas I actually have come home and said it can work. It may look differently, but actually we can apply these tenets as it ties to patient safety. So it seems simple, but it's very complex. In Kenyan, we say vitu kwa ground ni different. If any of my Kenyans can raise up your hand and say vitu kwa ground ni different, which I translate to saying taking theory into practice is complex. It's about behavior change. So we talk about teams, we talk about culture, we talk about leadership, and so on and so forth. All of those have to come together and marry themselves to make a system work. I can tell you in my experience, Jacaranda Health and so on right now with checkups, it's been about the people and making sure that we inculcate behaviors that tie to making patient safety a tenet in what we believe in, what we do, vision, mission, and then it cascades down. So we rely on competence, we rely on people to make it happen, systems and procedures that work. We talked about standardization, I've heard that come through. Then validation of what we're doing. Who comes to give us a report card to actually say what we're doing works, and so on. So it's a series of interventions at different places that start with leadership, strategy, vision, empowering our teams to work, environments that are enabling, and then monitoring and evaluating what we're doing, and then making sure that our patients are served as it ties to our teams being empowered to serve our patients. So I'll start there. So I'm trying to, there we go. So we have definitions, and I'm not going to go into that because time is a constraint right now, but we have several different definitions. There are several that tie to reducing risk and safety. And when we talk about a strengthened healthcare system, patient safety is a true area of need and concern because it's about ensuring that people get the outcome that they need or desire when they access our healthcare facilities. Now, patient safety is all about safe care within institutions that have put in place systems and processes linked to standards to drive predictable outcomes. And in terms of making sure that patients receive high quality service. When you access a healthcare facility, do you receive the care you need in a timely fashion? Is it not delayed? Is it patient-centered, efficient, and effective? And if people know the tenets of patient quality, STEEP is what I'm referring to. And so, you know, there are gaps, and we're not going to be, very, there are gaps, and we've talked about that. So looking at healthcare facilities within developing countries, there's a huge gap between what we need and also what we have. Typically, human resources are lacking. And I like to talk very, very freely and very, very candidly because, you know, with COVID and so on, we've seen where the gaps, and it was highlighted or illuminated in so many different ways. We were not prepared. We could have been, but we were just not prepared. So there's a gap in human resources. The quality of supply chain is not consistent. Infrastructure is not purpose-built. There's a lack of appropriate technology to enable information sharing that drives practice. The financing mechanism, we don't like to talk money with health, but we should, is failing such that healthcare facilities do not have adequate resources, be it people, be it equipment, be it infrastructure, and so on. So there's a gap. Questions that arise are healthcare facilities getting data to make informed decisions? What information are they getting to make informed decisions? Are we measuring the right indicators to make sure that we are building a system that is holistic and works? Are there recognition programs that are elevating what healthcare professionals are doing? I'm very big on elevating our healthcare professionals because they are actually the backbone to what we're doing. Is the voice of the customer valuable? Patient satisfaction and so on, their experience, is it valuable? Are we making informed investments? So are we able to actually unpack what is happening in our healthcare facilities to be able to make necessary investments that are informed? These are some of the things we need to think about if we're committed to actually designing ecosystems that place safety at the forefront. We talk about healthcare, we talk about healthcare, we talk about heal, then health, then care. I would love for our health practitioners to just think about that whole sentence in itself being one word, but breaks down a lot of things that tie to caring and safety and what we're trying to do as healthcare professionals and seeing that we're building systems that work. Now, in my environment, because I'm in Kenya and I'm giving this as an example, healthcare was recognized as a pillar towards goals as a presidential campaign. And universal health coverage has been a resounding topic. Now that's another thing that we're politicking on. We see that there's increased visibility on what is right or what is going right. But most importantly, we're seeing where opportunities, I don't want to say challenges because that's the easy word to say, but they're opportunities. We see sentinel events and incidents that are being illuminated on a national level. Never used to happen, which then feeds to organizational facility level plans and structure. So once we come there, how do we cascade what are lessons learned to the facility level and structures to ensure patient safety is linked to addressing international patient safety goals. Okay. So here, actually, we have global standards have been designed and implemented. These have also been adapted. So we have international standards, which is our hierarchy, WHO and so on and so forth. That's great. But how do we adapt them at the national level? I'm in a sub-Saharan third world developing country where there are constraints, and how we approach things are differently. That doesn't mean we're trying to minimize what happens. It's saying, how do I make sure what happens fits within my set environment so that I can meet the international standard? And that's what we're always striving to do. So these have also been adapted to reflect the set environment and key priorities. So we now have national priorities, Vision 2030, the health policy, constitutional priorities and all that. For example, in our environment, prevention of maternal mortality and postpartum hemorrhage is key, but we also should not lose sight of other critical components that link to overall patient safety. For example, hospital-acquired infections that impact patient length of stay. Patient identification to ensure interventions are implemented on the right patient at the right time, and so on and so forth. Falls that increase morbidity and injury, and so on. So we can say that I'm in a third country, the only thing that matters to me is maternal mortality. Guess what? No, because as my mother comes in and is in there, she has a surgical site infection. We then, with dirty hands, give her MRSA. She's staying in because she has a UTI, and so on and so forth. The cost of care has just surmounted to another level. And so when we think about things in silos, it actually is not helping us in looking at the system and addressing the system. And that's why I say, sometimes we try to hide away and say, I'm in a third world country. Oh, this is not my priority, this is another priority, when holistically we should be looking at the ecosystem and saying, if this woman comes in and out, what is the best way she comes in and out in the most affordable way possible without us inducing harm, because she could be getting up to go to the bathroom because she was in her bed and was not assisted, did not have a call button, and so on and so forth. Same situation that would happen at Johns Hopkins. And so we shouldn't hide from where our environments are, but say, how do we do it, and how do we do it in a cost-effective way that meets the needs of our consumer of health services and actually accelerates safety. Actually, before I go back, is that the criticality of constitutional and health policies on a national level is how does it sort of cascade to a facility level. And so it's critical because it lends to defining how our institutions customize policies, guidelines, and the way they institutionalize, inculcate their teams to adhere to them. So not only do we have pieces of paper, which when regulatory bodies are coming in, we can show, but do we have systems that flow, that when people come into our organizations, we orient them to what they are, tell them how we abide by what our mission and vision is, and how we inculcate adherence to them in terms of monitoring and evaluation. So what documentation systems do we have? How are we auditing? How are we measuring? How are we evaluating effectiveness of our interventions? And do people even know that? And that's why we talk about, as we onboard people, the way you did things here is not the way we did things there. If I came from Hopkins and came to Pumwani, the way, the formulary, the medicines, everything is different. But are there ways to structure how people are knowledgeable about how we operate, as this is a patient actually safety issue? And so we talked about audit mechanisms and so on to build external, internal evaluation, but what we also want to talk about external evaluation or validation through certification and accreditation programs. And that's where I prize IFC in terms of their checklists, SafeCare, JCI, and so on, in terms of putting standards that we can replicate across the board, and people can actually understand or risk assess their institutions to actually understand what they need to put in place if patient safety actually is a priority for them. So often we'll hear we did not have staffing, we did not have we couldn't document, we did not want to reference the protocol in front of the patient for fear of appearing incompetent. Please put your hands up if that resonates with you. Very basic things that we think are really, really basic, but are actually real outliers to making sure we are giving the best care to our patients. So I have an MO who has never treated a diagnosis for a very long time, was trained on it when they were in school, and yet does not want to access protocols on a phone of some sort because they don't want to look like they're incompetent. Looking at a protocol is actually, people don't want to document. So the photographs all look the same, right? And so on. If that's a real story, I'd love to hear some insights on that, because, we couldn't because we were short-staffed. And yet when that photograph was saying we are going into danger zone documentation, we did not address it because we felt that I didn't document, it wasn't done. I actually wasn't looking at the documentation. And therefore, I actually put my patient at risk. And we're talking about patient safety. Things that we can hide back on, but things that we need to address, because if leadership really is on our side, then these are the things we should be bringing to the forefront in a non-punitive environment to be able to actually address, so that we can invest in what we need to make sure that things are running safely. So patient safety aligns with continuous improvement, and it is about building systems that work. There are key ingredients that start with a vision and a strategy. We see that right there. To set the tone, it's about setting the tone and also prepare for necessary investments. The commitment to adopt an organizational culture. We've talked about culture. My two predecessors in speaking have talked about culture that values patient safety. So it's a reporting culture, non-punitive culture, where we focus on process, not punishing people. A continuous learning environment, incorporating audits, case reviews, ground rounds, annual competencies to elevate practice to be evidence-based, and also ensure the team's competency and skill are up to date. And in our world where healthcare is dynamic, this is happening on an ongoing basis and is not static. We talked about policies and SOPs to guide practice, but the need to generate data is key. Data is the new gold, and in every industry, particularly ours as well. What are we using to make decisions? What evidence, what proof are we using to make decisions? Or is it business as usual and we're functioning as hospitals that we're dealing with in the 1970s? You need to think about that. Using technology as an enabler to guide practice and drive informed decision-making. So I echo systems and processes linked to standards, which my predecessors have already sort of driven. The organizational culture. How do we do things? What is our performance and how do we manage performance? What is the attitude? Because that's a big thing in Africa. We talk about attitude, and yet we're putting people in unsafe environments and thinking that they should be just happy, whereas they want to do the best that they can do, but they're not in an enabling environment to do that. Competence, skill, it's changing every day. How are we enforcing or empowering our teams to be up to date? Customer care. We are a service industry. Passion, motivation. For me, that's where it came from as a clinician, passion and motivation. Everything came after that. But how are we driving that so that people are still within their realm to deliver what they want to deliver in the best way possible, and making sure that outcomes are relevant? It starts with leadership. We say that all the time. I happen to be a CEO of a company and have happened to, it's not easy. But when you're up there, you're looking at the ground. And when you're up there, leadership, you're by yourself, but you set the tone. And so it starts with leadership, willing, determined to make the changes and accept that changes need to be made, and commitment to say that I'm dedicated to be on this journey and I will support everyone, and to cascade down to the front line, to institute structures and invest in structures that place the patient at the center of it all. And when I say the patient at the center of it all, I never minimize the staff who are actually assisting, or actually technically the ones who are bringing everything together to make sure that our patients are served appropriately. Okay, so we talked about patient identification. I won't go too much into it because Dr. Williamson actually I had a full presentation on that. But I just want to give examples, just clear examples, because I've been in places where just things don't work. A name, an IBAN, identification, what are we using to say this is the right patient I'm dealing with? And sometimes we take it for granted. But in the newspaper, things that I showed you earlier, it caused harm. Just because I didn't have 3 identifiers, it caused harm. Now, in my set environment, interventions that seem so simple become complex and lead to harm. An example, 2 patients, John Smith, John Doe, and Joki Wanjohi, they have the same names, right? Names that are very, very common. You know, Mind, Faith, Kisibo, we don't see it too much. John Kamau, we see a lot. Joki Wanjohi, we see a lot. Now, yeah, so commonly used names and date of birth. They could have been born on the same day. It's very, very possible. In fact, when they are born on Christmas Day, very, very possible, right? They arrive to an institution, typically based on lack of staff, time constraints, ineffective medical record systems, electronic or paper-based, it doesn't matter. We find patients being identified by 2 names. Yes, 2 names, a telephone number where here in Kenya, where 90% penetration of mobile and so on and so forth, numbers are changing every day, right? It's a shared phone number. They lost their other phone number, so they got another Safaricom line or another Airtel line. Reality is that phone number is not a consistent way to identify a person because it is revolving. So what things are, and then the last thing is we identify with an invoice number. Why? Because I'm a small SME and my priority is getting money, right? Not safety. So when you look at this picture, you wonder what is happening. Whereas, you know what? 3 names, right? Because, you know, a lot of that middle name will be very, very different. So where in actual fact, key differentiating factors are the middle name, your ID number, or birth notification number if you're a neonate or you're a minor, your medical record number. We don't have medical records that make sense. And so when people come in, we just charge them to the invoice number, and yet we don't start a file. And when I say that, I'm talking about our HSMEs, because we can also talk about our larger hospitals, which have adopted a lot of westernized approaches. But let's talk about the real, where we are on the ground. We haven't started a medical record that links to this person as an individual, which lends to processes where at least 3 identifiers are used to ensure the correct person, procedure, medication are provided to the right person, right time. For me, when I was coming up clinically, there are now 7 rights, whatever, it was the 5 rights. Now, introducing documentation, and Dr. Williamson talked about that. WHO checklist, right? Surgical checklist, a timeout process as a key verification stage. In my setting, we've had cases, and actually this has been in the paper, where non-responsive patients, where identifiers were not adhered to, and the wrong patient received the wrong neurosurgical procedure because at various touch points, Dr. Williamson showed us a whole map and said, where can things go wrong? I say touch points. There are various touch points and all of them are where things can go wrong. Handover, checklists are not adhered to, which led to wrong medical record in the OR and therefore wrong procedure to the wrong patient. The first reaction here was to fire the neurosurgeon and the nurses who are involved, as opposed to performing an RCA, a root cause analysis, to understand areas of improvement. So we're rich to be punitive and yet not rich in interrogating systems to actually see what do we need to do better, because clearly there's a system problem and not a person problem. There have been cases at childbirth, and Kenyans with me can maybe articulate this, where triplets, where post C-section, the neonate is whisked. This happened to me in Uganda. The neonate is whisked post-surgery with no identification that links to the mother. Put in a wonderful wrapped blue, but all the kids were wrapped in blue. So I don't know who that child belongs to. Now here, 19 years later, due to distinct similarity, people in the community, they look the same. Why do they look the same? And so on. Asking questions and questions. DNA tests, 19 data were conducted and found that there were actually triplets who are actual siblings. Therefore, these are just a few examples on the criticality of building systems that adhere to process linked to patient identification, and harm can occur if not. I'll go to falls, and I'm just about to wrap up. Falls, most of the time preventable, but when they occur, have the ability, depending on age, physical and cognitive disposition, have an increasing negative impact on prognosis, particularly with our geriatric populations, I'll say that. Most of the time falls occur because one is disoriented and not adjusted to the set environment. It's new. Yeah, I'm in a new environment. They're throwing me off at night. I don't know where I am. They're on medication. That also throws their cognitive abilities a little bit off. Basic needs have not been met. They're thirsty. Did we know that? Did we even ask? Toileting. Most of the time, they usually want to jump and go to the toilet. And that's where they're veering to. But their side rails are up. Yeah, their call bell is not in place. Their bed is not low enough. And before I left the room, I actually didn't inquire if there's anything I could do to help you. So when we talk about fall prevention programs, which is a task, it's about setting behaviors that are inculcated into culture and becomes a way of life. And so in this slide, you can see everything I've said. It's in terms of who is my patient? Do I know what they are? What do they need? Have their needs been met? Is there a mechanism for them to reach out for help? Is their bed in the lowest dim? Are we checking? Are we documenting? And then are we monitoring and evaluating? Right? So here's the power of data, and we move to the power of data in terms of, in all these things that we're saying in terms of international patient safety goals, what is our measurement mechanism? And we have something basic and not very complex. And these are dashboards, which I implemented within our facilities. Excel sheets that are red, green, yellow, that are telling you, okay, red, danger, green, we're okay, yellow, we need a plan. And so data is a powerful tool to monitor trends, to make proactive decisions. In my experience, we've created dashboards on Excel and have clinical as well as operational metrics as well. Hand hygiene compliance, using secret shoppers to conduct observations, but building safe spaces to conduct conversations on what is working, what's not happening. Patient satisfaction rates, how are we gathering that information? When is the best time? When is the best place? CORTI, CLABSI, VAP, HAIs, right? All mostly acquired on hospital admission. Armed team, do we have an armed team? Or departmental structured discussions to plan, but also celebrate the wins when goals are met. And hear me when I say celebrate the wins, because most often we are actually beating down our teams for what's not happening, but not celebrating or showcasing what is happening to motivate them. So how do we create safe environments to deliberate and make decisions that are consistent? The dashboard acts as a key communication tool, but there are also other ways in terms of incident reporting. For example, a near miss of an actual fall to give teams opportunities to conduct RCAs, root cause analysis, to design improved interventions. This means activating that Kaizen button. So we're going to Toyota mode. If you're Lean Six Sigma, this is something that's not very new to you. Patient safety. How do you pull that button to say something's not working and we need to address it? I'm concluding by saying, and sorry for rushing through this, I often discuss with my team that we are in the business of health, and patient safety is paramount in all we do. It's about building a system that prioritizes reducing risk and increasing safety. Organizational cultures that keeps on coming up, the way of life in our organization that thrive on accountability and transparency. A focus on the patient at the center, and valuing and equipping and upskilling the staff who anchor this all. In Africa, I can't tell you how that is very important, but focusing on the staff who anchor on this all is critical. The need to drive practice and supportive evidence is key to taking research to the bedside. and to design effective interventions. So it's key to understand that based on different settings, interventions, and Julia said this may not look the same, but costs may be different, they may look different, but the overarching goal is the same. And that's creating an environment that values safety. Thank you.
Thank you very much, Faith. Great examples, great presentation. And thanks a lot to our participants who are staying much longer than expected with us. We hope that you find it useful. We hope that it means that you find it useful. And now we move to question and answer session. It will not be long, unfortunately, but we are sure that you will find lots of answers to the questions which relate to the implementation of international patient safety goals in our online training modules. And we will share the link to them once again. And we believe that you will find it useful, and lots of the questions that you asked today, you will find answers there. I want to repeat it several times to make it clear that lots of gaps and lots of solutions you will find there, and lots of gaps which are common. But let's take one more thing. We receive lots of questions which relate to the implementation of policies and procedures and which relate to creating culture. We had a separate webinar on staff resistance, and you can find it on the IFC website with the link, the recording of the webinar. So we will not be covering these questions today. Unfortunately, we will talk about specific issues which relate to international patient safety goals implementation. And the first question is how to audit hand hygiene and maybe also fall and identification processes. Maybe our speakers can give tips on how to efficiently audit this, because it's a very common question. Who would like to start? Actually, this question was addressed to Faith, but maybe our other speakers want to start. Dr. Ashraf or Joseph?
I recommend Joseph to start.
Thank you. Thank you, Dr. Ashraf.
Thank you, Dr. Ashraf. I owe you a dinner for that one. So here's the problem with audits. Here's a number one problem that I find with hospital audits. I think the number one problem is that most hospitals bite off more than they can chew with audits. They say, okay, we're going to audit a process. They don't begin with, okay, how am I auditing that process? What department is going to be directed to that audit? Who's going to take part in that audit? How am I going to collect the data? How am I going to interpret the data? And you can see the list of questions will go on and on and on. So my number one advice to, and I see this question here, to anybody that's going to start an audit is pick a department and pick a process. Don't say we're going to audit the entire hospital process, because you will just frustrate your employees, frustrate your staff, and you won't get anything done. So for instance, I'll give you an example. We audited the rate of C-section infection in our labor and delivery. That was one process, one audit. Then we said, okay, now that we're auditing this, what type of audit are we going to do? Are we going to do where I watch every doctor that goes into surgery, or I'm going to do an audit where it's virtual? We had to decide that first. After we did that, then we started going, okay, what period of time is this audit going to be processed against? It's going to be 1 month, 6 months, 1 year. It depends on your staff. The number one thing then becomes communication. Get your staff's buy-in on that audit. Don't just come up with an audit and then tomorrow say, hey, by the way, we're auditing C-section rates, because nobody will comply. They will all not understand why you're doing it. So one, get the buy-in, and two, focus on the process, focus on the actual process of auditing. You can go on forever and ever on this. We could actually have a whole webinar on auditing processes if we think about it, right? So I'll turn it over to my esteemed colleague there, because I see you nodding.
I agree 100%, Joseph. This is a whole process, and it's also part of the culture. People should understand why we audit and what is the value of this audit, and not only just we are auditing to pick up mistakes or to catch them when they do something wrong. That's why people are under a lot of effects that somebody's watching me, somebody's over my shoulder, so they are nervous about this, and they maybe report wrong or false information. the auditing, yes, it is a process. People should understand it. And the person who is doing the audit should do it consistently with criteria for this audit, because in hand washing, for example, if you are going to observe hand washing, what are you observing? And the consistency of the hand washing process. Is it taking the right time to do it? Is it done every time it should be done? All the elements should be audited, and the knowledge of people about the audit actually in itself make them feel that there is always observation, there is always monitoring. So this helps the process itself to be done and to be part of the DNA of the work and the organization there. But if it is done sporadically, it is done only during campaigns or during certain occasions, or because becomes a hot issue suddenly or something, people they just do it to show that they are doing it, and usually this yields false information. So I think the whole process really should be done consistently, objectively, with no pointing fingers, and also audit should include the reasons why people are not washing their hands. For example, maybe the problem with the washing basins, the water availability, the soap availability, maybe why people are allergic from certain kind of gel or certain kinds of soap. That's why they don't use it all the time. All those reasons also should be investigated and audited to reach to the real reasons and to do it right.
Definitely. And can I just add one thing before you go, Faith?
Yes,
after the audit, make sure you round with your staff. Okay.
Absolutely.
You now have all these numbers, right? And you now have told your staff they're doing things wrong. Round with them. Find out, why are you doing things wrong? Is there a problem?
Yes.
Because that will come out in the communication. I'm a big component of rounding. 8 o'clock in the morning, 12 o'clock at noon, and 5 o'clock before I discharge my staff, we're rounding with the staff. Constant communication.
So I think you can see people are just passionate in this realm. So let me just, yeah, and we won't stop. But let me tell you, a key thing is leadership oversight on what is happening on the ground. If there's no reporting mechanism or no KPIs that the leaders are aligned to, even if it's simple as hand hygiene, hospital-acquired infections, and so on, then it's a wash. So the KPIs that are held to the ground are actually held at a strategic level when they're actually reporting to the board. And let me tell you, in the US, if I got JCI accreditation, if I was able to show that my UTI rates were going down and Medicaid was supposed to appear like NHIF was able to reimburse me, I got a bonus. So there were incentivized plans to me making this work. So it became now a strategic force to making it worse. Number two, when we're talking about information that's going to the front line, when investing in a quality department is key. So don't think that the nurses are just gonna do it. The doctors are gonna do it. Actually investing in a QI department is strategic to making that goal happen. Because we think here that everybody can do everything, whereas this is the lab lead, pharmacy lead, he has this job, it becomes a lack of priority. So actually an investment in that department is key, and who is there is key. Three, the information that is being filtered down to the ground is digestible. When I had UTIs, the goal was QI would say UTI by per catheter goals, days, something, something, something. My team didn't understand that. I had to translate. Guess what? Last month, we did 6 infections where our goal is 0. So this month, we did 2. So yay, let's celebrate. So translating information in a way that is digestible to the people who are doing the work, so that in our team meetings, we're strategizing how to get to the goals that we want, is very, very important.
Thank you very much, Faith. thanks to our speakers for this great answer. And we will take just 2 more questions because we're really running out of time today. But fortunately, most of our attendees still stay with us. And thank you very much for that, because I think it's a super hot topic and very interesting discussion today. So before we move to the next question, I also wanted to stress once again that you can see that in patient safety, there are no minor things or you cannot cut corners. Everything is super important. And also we believe that you will find lots of useful tips regarding the auditing processes in all our modules. And also we believe that our modules will help you build the culture, because on the one hand, they explain how to do it. And on the other hand, if your staff use these online training modules and it will be kind of buy-in for them. They will understand it better and probably they will like it better. So please try and use it. So the next question will be a tricky one. And actually, we talked a lot about the role of the infrastructure in patient safety and that this is the key, this is the basis. And we received one question regarding the private hospitals and clinics in Egypt, actually, but this is an issue in many countries, which are located, for instance, in residential buildings. And the question, it's a wider question. It actually relates only indirectly to international patient safety goals, because how in that infrastructure, which is not perfect in itself, how to make it more compliant. And is it an obstacle or maybe it's not an obstacle? So what our speakers would say to that, it's a very common question.
I will start responding to this question, and I agree 100%. This is a huge problem worldwide. It's not only in Egypt, but I saw it happening here in Egypt in many places. And I saw places that have challenges with water supply, with waste management, with elevators, with fire safety, with all issues that is related to infrastructure and structure, and not only threat to the hospital or the care itself, but threat also to the community, because the hospital has a lot of waste, a lot of problem that can be reflected on the residential areas where they are located. Solution that some countries actually took, and they could afford doing this, was what happened in Abu Dhabi. Abu Dhabi issued a decree that in 5 years, that was issued like 3-4 years ago, in 5 years, there would be no hospitals licensed in a residential building. And if a hospital need to have the whole building and renovate it and transform it into a healthy environment, that would be acceptable, but they should move totally to a building that is built to meet the requirements. So that is a radical solution. But still in some of those residential areas, there are some innovative solutions that can provide some safety issues. Those should be enforced, especially when it comes with life safety codes and with fire safety, with infection control, with waste management. If those can be implemented, and actually we are working now with the code. There's Egyptian code for building hospitals and renovating hospitals. We are renewing the code to include all those requirements to make sure that unless the organization, the hospitals, the medical centers would comply with those standards, there should be no relicensure for those hospitals to function as hospitals. Definitely accreditation, it depends on the license, and the license when it is given in some countries also, including Egypt, the license is given like once per life. I mean, it is not relicensed every number of years. Now the law is going to change that, because licensure should not be forever. It should be, so the relicensure should not really be given unless the facility meets the requirements that are essential for structure and infrastructure. New technologies in issues like ventilation, like water, like isolation, like positive pressure, negative pressure, etc. Give some solution that can help. But unless we meet this, definitely actions should be taken in order to protect the patients and protect the workers from the hazards of being in these places.
Thank you very much, Dr. Ashraf. Actually, our previous webinar was on the role of the infrastructure and ways to improve and also to become more compliant and more safe for patients in a compromised infrastructure. So you may find it useful to watch it in the recording. It is available on the website. And one last question that we will take. Unfortunately, we are limited in time, although we wish to continue, of course, this interesting discussion relates to it was actually a question to me, but I'm sure our speakers will be also will have something to say on this. So what are the lessons that we learned from the patient identification when we assess patient identification, when we see how other hospitals are doing it? And I'll just answer briefly. I'm sure we talked a lot today about the patient identification and the possible gaps. Actually, these are the lessons. We learned the lesson that many hospitals misinterpret the requirements. It's difficult to choose the right identifiers, and Faith gave a wonderful example, which is so common for many countries, not only in Africa, but in lots of countries, that patients might have similar names, that not in every country ID number or telephone number is a reliable identifier. And as Joseph said, location is never a reliable identifier, actually is a dangerous identifier. So these are the lessons briefly that I personally learned. And now I move the floor to our speakers, and this will be our last question for today, unfortunately, before we conclude.
In fact, the risk for patient identification is huge range. And I would emphasize that patient identification, as my colleagues also mentioned in their examples, can be killers. And mistakes in patient identification, I witnessed this myself in some published events in one of the large hospitals in East America, that when they were wrong in identifying the patient who switched their beds in one occasion, they gave the wrong blood to the wrong patient. She immediately died because of the person who gave the blood did not check the band and took it for granted that she is the one next to the door, not the one next to the window. And that was a very famous issue. The other problem with medication dose, the dose of adrenaline that was given to a child 9 years old instead of an adult, which is like 10 times the dose, and he's immediately died after a tonsillectomy operation as well, because they failed to identify the patient and they give it as the wrong side surgery. As Joseph said, it happens all the time. When they remove the right kidney and they leave the diseased kidney, and the patient has renal failure forever and they could not sustain their life. The examples are so many for identification, and the range is sometimes nothing happens and they just discovered it's a miss happening and doesn't lead to serious, but it does lead to serious issues in many occasions. So I think the actions on this is there is no compromise in this. It is a whole organizational issue. It is a leadership issue. It is a responsibility of everyone. And I cannot add more than this. My colleagues may also share their thoughts about that.
So, oh, sorry, go ahead.
No, go right ahead, my dear, go right ahead.
No, I was going to say, what is the role of the regulator? Because even as private sector, what is the role? Because regulation cuts across public and private. And we tend to see that it is enforced when something bad happens, but it's not enforced in terms of certain standards that have been put in place that we have to adhere to. And so things like identification, if the government has not mandated that in every healthcare institution, this is how somebody is identified, it means that every institution just does whatever they want. and that's unsafe. Having lived in the Western world for a while, my name, my ID, my date of birth, but my social security number became that unique identifier, and not my phone number. And so what things do we have? Because we have, in Kenya, we have NSSF numbers, we have NHIF numbers, we have unique identifiers that we have just decided we're not going to use. Whereas if you look at institutions elsewhere, they are unique identifiers that are mandated, that if a regulatory comes in and you cannot show this, there's actually action that is going to be taken. So I think there's things that need to be taken more seriously, and regulation plays a huge part in that, because when we leave it to private sector, we do it by choice, and it shouldn't be a choice in private or public sector. It should be a standard across the board, because I will go into a public institution or a private institution. It doesn't matter where, the treatment must be the same. Yeah.
I can give you an example. In my country, where I'm from, Jamaica, years and years ago, the identification of patient was a choice. Basically, their house number, their telephone number, their license plate number, whatever, because they just needed to do it. One thing happened. It always takes just one time for them to learn a lesson, where a woman comes in the middle of the night, pelvic pain, they do an ultrasound, they find ovarian torsion. They send her to surgery. The surgeon is coming in. They did not class the woman's name. There was another woman with the same type of surgery. However, this woman only had one ovary. Okay. So instead of waiting for the GYN specialist to come in to deal with that woman, they sent the surgeon to the wrong patient. He took out the ovary. Now the woman can't have children for the rest of her life, instead of waiting for the GYN to come in and untours the ovary. After that, and that was in a public hospital, one of the biggest public hospitals in the Caribbean, the law changed, because now they're using government number instead of license plate, whatever, because that government number you're born with and you die with, right? So that is the unique identifier. And after that, the laws change. My colleague before me said it cannot be a choice. It cannot. We can't do that. We cannot say we'll do it sometimes and do it other times, because if my relative or myself is ending up in that hospital, I want to make sure that you have the right identifier, because I don't want to die and I don't want my patients to die. So I think that that's the overall message from here. There's no compromise in patient. I may be able to compromise in the amount of hand wash stations I have, but I cannot compromise in my patient identification. End all.
Thanks a lot. I'm afraid this was our last question for today, and our session is today extremely long, actually longest than ever. Today is the second anniversary of our webinars, as Natasha said at the beginning, because we started our webinars 2 years ago in October, and this is the first such long session. So I wanted to thank our wonderful speakers today, Dr. Ashraf, Faith, Joseph. Thanks a lot for excellent discussion. I also wanted to thank our attendees and our participants, our guests today. I hope you found it useful. I hope that we at least partially answered your questions. Unfortunately, we have time restrictions, and we wish we could have a more continuous discussion, but I'm sure you'll have other duties to perform. So thanks a lot for being with us. And Natasha asked me to pass the floor to her for a little announcement. Natasha, and I say goodbye to everyone. Thanks.
Thank you very much. So there is one important announcement that I'd like to make. From the list of participants, we see that some of you shared the link. You registered, and then you provided your link to someone who you know, your colleague or your friend, to listen to the webinar. This is absolutely fine, but there is one important note to be made. If you only registered once and you only used one email for the registration, then the slides and the email that we will be sending you tomorrow, they will only come to your registration email. Unfortunately, if you did not register, but you used somebody else's link, then the materials from this webinar will not come to you. You will need to send us your email or ask your colleague or the person who shared the link to share with you the email that we will send tomorrow. So this was one important announcement for you, because if you wait for our slides tomorrow and they do not come, you will feel not good. And this is the possible reason for that. So please consider this. And also when we finish our webinar now, when you exit, there will be 3 questions that we'd like you to answer. And we will be very grateful if you do that. Thank you very much. And we hope this was useful for you. And we hope to see you again at our next webinar that will cover 3 more international patient safety goals. And we will hold this webinar in November. Thank you.
Thank you very much. Bye.
Thank you.